And I'm also aware that being the last person to speak in the day is a little bit like being the niftar, the corpse at the funeral. You're necessary to the occasion, but nobody wants to hear you say too much. So I would like to take up Rafi's challenge on hope or hype, and to start with the realization that the challenges for Israel are very different from the challenges for the United States, and recognize that this is part of why Marcia and I decided that we would spend the rest of our careers working on these challenges, because they're both so much more interesting and so much more promising. Israel is sitting with one of the highest life expectancies in the world and one of the lowest costs per capita of medical care in the world. So our cost per person to treat a human being during his or her lifetime is approximately a third of the cost per capita of the United States. Israel is spending 8% of its gross domestic product on health care, and the United States is now spending more than 20% of its gross domestic product on caring for its citizens, and yet Israel is getting more for its money. Now, the problem with that is that with increased life expectancy comes a welcome but massive increased demand on the healthcare system, because the longer people live, the more care they're going to need. We're also at a point in time where medicine has changed in ways that we don't even recognize in the last century compared to the first 5,000 years of human medicine. 100 years ago, very little of healthcare involved the care of chronic illness. Medical care was about treating acute infections, cutting off gangrenous arms and legs, fixing broken bones, and now 86% of healthcare spending is focused on the care of chronic disease, and it's only going to grow. So rising need translates to rising cost, and there are really only three different ways to address the cost problem. One is you simply deny care to people and say, I'm sorry, we're not going to treat that condition. In the UK, for instance, if you reach a certain age, you're just no longer eligible for a pacemaker, because they know from the Bible that the age of man is 70. And once you reach that age, we will give you a comfortable death. So that's one approach to dealing with rising cost. I'm not saying it's the best one, but it's one that some countries implement. Another is simply to pay doctors and hospitals less for doing the same thing. And that works until they start to go out of business and just do other things. And then the third option for dealing with rising need is to use technology in a way that we reduce the need for expensive care and we make care less expensive. And to me, that's the only option. So digital health is really the key solution in that third option in 4 different ways. The first wave was the use of big data to identify problems, intervene, and monitor solutions. The second is the use of electronic medical records to reduce medical error and duplication of services. The third is the use of ambulatory devices to monitor chronic illness and improve outcomes. And lastly, the use of digital technology to actually reinvent what we think of when we talk about a hospital. So I first got involved in big data in 1988 when I was given the chance to go over to Medicare as an expert consultant and work with some troublemakers who took the Medicare billing data and used it to show that there were huge differences in the likelihood that you would be alive 6 months after having the same procedure at different hospitals across the United States. Johns Hopkins happened to look very good, fortunately for my job. But the New York Health and Hospital systems looked like it ought to be closed. Unfortunately, the next commissioner of Medicare was the head of the New York Health and Hospital system, so we all got fired for that. But that kind of use of big data really changes the way we look at our healthcare system and look at what we need to fix. My next adventure in big data was a company called Active Health Management, which is now part of Aetna, and its technology has been copied by every insurance company in the US and probably by most insurance companies in the world. Looking at the claims stream, looking at the pharmacy data, just the basic billing data, even before you have electronic medical records, to identify common medical errors. For instance, it's well known if you read the label that people on nitrates shouldn't be taking Viagra because that's a fatal contraindication. But on a daily basis, you can identify people where one doctor gave one drug, one doctor gave the other drug, and you can actually reach out to patients and stop the problem in time. Or people who have had a heart attack, but nobody gave them a prescription for beta blockers, where everybody knows that adding beta blockers reduces the likelihood of a second heart attack by about 50%. So with very simple uses of big data, we show that you could reduce hospital input in hospital admission about 6% and medical cost about 8%. Again, just taking the low-lying fruit. One of the earliest triumphs was shown right here in Israel by Maccabi when they implemented an electronic medical record system a little bit ahead of the game, and very early on showed how just by watching what was happening within their pharmacy system, they could track who needs to be on a statin, getting more people on statins, and showed a reduction in low-density lipoprotein as a result. So just taking the claims data has already started to prove that it's hope and results, not just hype. Now, electronic medical records, that's kind of the cutting edge. And there are two things that I can tell you that were absolutely certain in 2000. One was that President George W. Bush had absolutely no intention of attacking Iraq, and the other is that he had absolutely no intention of computerizing every medical record in the United States. At the same time, it turns out that he did both. And the secret ingredient, in fact, was somebody nobody's ever heard of, who was my friend, but his college classmate, Rex Cowdery, who could always get us in for a secret meeting when the political staff would block what we were trying to do. But even though the presidential order was signed, even though the Office of the National Coordinator for Health IT is now a huge and successful enterprise, the United States has not yet proven that this multi-billion-dollar investment in electronic medical records has paid off, although we continue to project that it will. Yet at the same time, in Israel, the proof is already in hand. And this is an article that was published by my colleagues at the Brookdale Institute in Yerushalayim, showing that between 2005 and 2007, using the investment that was already made in electronic medical records, Israel achieved a gain of 6.7% in 9 different measures of primary care quality, while the US performance on those same measures declined. So there's no question that if you're determined to use electronic medical record systems in order to improve care, in order to meet benchmarks, the opportunity is there, it's real, and in Israel we're already doing it. So I've spent the last 6 years of my life focused on how do you make medical devices talk to the cloud in a way that you can change people's health care. And I'm actually sort of to outside the circle in that I think the devices themselves need to talk directly to the cloud, that generally when you try to link things to cell phones, it becomes a real ergonomic problem for people. The good news, though, is that the same Qualcomm radio chip that cost $150 when I embarked on this can now be had in Asia in single-digit dollars. So we're going to see a world where instead of your cell phone being the hub of everything, we're going to see a world where every medical device has its own little cell phone inside and is talking to the cloud. And those devices are, we've put 50,000 of these in people's hands so far. Well, why diabetes? Why use this as a demo? Because diabetes is one more chronic illness where we have the drugs, we have the technology, we know what we need to do. if you can get people to do what they need to do, you can cut the costs of the disease in half. There's no question about that. The only question is, what does it take to do what people need to do? And here's a paper we published in US Endocrinology showing that if you take a police department in Louisiana, imagine people sitting in cars and eating donuts. Take the people who have diabetes, get half of them to use a wireless medical device like this that connects them not even to their doctor, but just to somebody in a call center who can talk to them about the fact that their blood sugar hit 400 yesterday, versus leave people to do what they were doing before. You can cut their medical costs in half, in US terms, save $3,500 per person per year, just with that simple intervention that didn't add any cost to the system. Not only can you do it for diabetes, you can do it for asthma. 5,000 American children die of asthma every year on the way to the hospital simply because nobody knew that they were wheezing at breakfast. If you can identify the fact that they're wheezing at breakfast and add another 2 puffs of oral steroids, that child's not going to the emergency room that day. Obvious opportunity for that same sort of wireless device. And take a look at what's happened in cardiology. This is what a Holter used to look like, and now a Holter is a Band-Aid. Now you have the opportunity to send somebody home, spot the dysrhythmia, and even potentially have them take out their iPhone and cardiovert themselves. That may be tomorrow's technology, but spotting the dysrhythmia is today's technology. So the challenge then, given that these devices are coming, is, what's the critical need? Why do I say that digital health is really the only hope? Well, Israel has a unique problem. Israel started out with fewer hospital beds per 1,000 than most of the OECD countries. Is already starting with a gap of about 1.5 hospital beds per 1,000 compared to most European countries to the United States. There's nobody who works at Rambam who doesn't understand that just about every Israeli hospital is at full capacity and beyond full capacity every single day, whereas there's no American hospital that doesn't have a couple of empty beds that they could do something with at any given minute. And there's actually been a 7% decline in beds per 1,000 in Israel since 2005, and an evolving public belief that the bed constraints, the system constraints are such that length of stay is becoming shortened to the point where it actually contributes to rehospitalization. So in this way, Israel is starting to confront the breaking point because it's impossible for Israel to build enough traditional hospitals quickly enough to close the gap, even if building a lot more old-fashioned hospitals was a good idea. So then the question is, what do you do? Well, people are already realizing that a lot of the things that used to have to be done in a hospital don't really have to be done in a hospital anymore. And here's an initiative that has been launched at Johns Hopkins, and it's certainly not the only initiative in the world, to be able to provide high-quality care for most conditions right in the patient's home. Most people need some fairly basic things at home. They need real telemetry, real-time telemetry, so that if there's a problem, somebody in command knows what's going on immediately. They need monitored medication delivery, so that the medication delivery one would get at home is every bit as reliable and advanced as the medication one would get in the hospital. Frequent contact with healthcare professionals, even if that healthcare professional is transmitting his body through the agency of a robot. People need some sort of face-to-face interactions with their doctors. And if we're going to talk about hospitalizing people at home, we have to figure out how to give people that sort of hands-on face-to-face interaction as well as the in-person interaction from other healthcare professionals who can be in that person's home in person and in body. People need, of course, housekeeping and dietary needs, and they need immediate access to more advanced levels of care should their condition go in the wrong direction. Well, those are the things you can get from a hospital at home. There are also some very important things that you don't get from a hospital at home. You don't get daily exposure to life-threatening hospital-acquired infections, particularly if you're an elderly person who's otherwise susceptible to those infections. You don't get the kind of loss of sleep that being in a hospital with alarms going off, lights going on, that kind of sleep disruption is known to be counterproductive to healing. You don't get the loss of privacy and autonomy, which no matter how hard we try, is part of an inpatient hospitalization. You don't get the huge disruption in the family cycle of having people constantly leaving what they were having to do every day to visit their relative in the hospital, and you don't get the disorientation and depression that occurs when you take elderly people out of a familiar environment and put them into an acute inpatient setting. So there's a huge opportunity if we can figure out how to do this right. If we can't figure out how to do this right, we're going to be seeing, I hope Rafi doesn't hold this against me forever, but we're going to be seeing tents on the plaza outside of Israel's hospital holding temporary beds because there's just no more room inside. So when you say digital health, hope or hype, I think digital health at the end of the day is really our only hope. So thank you.